All right, kia ora everybody. I am Gary Payinda. I'm an emergency doctor, which is a little bit unusual for assisted dying. I have worked here in town for about 18 years now in the emergency department. And maybe 5 years ago, when the law was being discussed and debated and the opportunity rose to support it, I supported it with sort of testimony and evidence and helped try to get it passed. It passed with, I think, a 2/3 majority of voters. And for like the past, 4 or 5 years, assisted dying has been legal here. So I'll give you a little bit of background on how the process works and how the law works. I think the first thing to realize is that it's not really set up as an emergency procedure. So if a patient rings me and says, I need it and I need it now, I'm in hospital, I have a bowel obstruction, I'm dying, it doesn't apply to you. If a person has dementia, and I know this will be a question that I'm going to preempt it, because this is like, how many of you have a question about dementia and this law? How many? Look, so we know that's an issue. The law doesn't apply to that. A person, unfortunately, needs to be fully aware and able to give informed consent at every time. When I see you the first time, when I see you the second time, when the second opinion doctor visits you, and on the final day. You can't set it up in reserve ahead of time for when I'm incapacitated later. It just doesn't work that way. Some of you might say, why is that? Why does it work that way when so many people obviously want it? And the reality is the law was written in a better way when it was first proposed. But in order to get it passed, compromises had to be made. And some of those compromises resulted in many more hoops and hurdles and delays to patients seeking assisted dying. And so the reality is we have a law that has there's a lot of barriers in the way to getting it. And I'm going to go through some of it today, so it's clear in your mind of how one accesses the law, what circumstances it applies to, and how it could be made better or a bit more humane. But going back to when the law was passed, there was obviously concerns that it could be twisted and used in unintended ways and abused. And I think we need to address those because it may be a little bit different than what you think. So there was a big emphasis on any assisted dying law not being prone to abuse by family members or friends who have something to gain, pressuring the person into assisted dying. And I think what is interesting, having worked now with hundreds of patients over these 4 or 5 years, however long it's been legal, what's been fascinating to me is that this is like the law of unintended consequences. That has not been a serious issue. It's very rare. But I'll tell you what kind of pressure on the dying patient is incredibly common. The feeling by the dying patient themselves that their family is pressuring them to stay around longer at any expense. You might, obviously, if you're in this room, you probably are not among the people that would do that to a loved one, but a lot of people would, probably out of a sense of guilt or fear or who knows. But there's a lot of pressure put on dying patients, suffering patients, to conform to the wishes of sometimes even people not in their immediate circle, but like extended family, who all of a sudden, the eldest daughter comes back from Australia, or a son-in-law or someone starts essentially trying to pressure a patient to make a different decision than the one that they originally started out with. And that is actually quite prevalent. So it's quite fascinating how the pressure ended up being almost the opposite of what people thought. Other things people don't think about is that this is kind of it's a Goldilocks situation to get assisted dying. You can't be too sick. I told you that if one of my patients calls me and says, I need help now, I have to tell them essentially that this is, it's essentially a political and a legalistic and a bureaucratic process that we have to go through with a lot of paperwork, a lot of questionnaires, and you can't, even if you're suffering right now, you can't rush that process along. It runs its course. So something that some of you might want to think about is that if you want to apply for it, you need to be in this very strange little window, right in the middle, not too sick, where you will lose capacity to give informed consent, or you can't wait the 2 to 3 weeks that it will take to get assisted dying. But you also can't be too well, because one of the basic bits of the law is a 6-month rule that says you've got to have a doctor, whether it's myself or your cancer specialist or your general surgeon or your GP, that is willing to say your prognosis is 6 months or less. Now, I want you to, let's spend a minute and think about what that means. Doctors are honestly not very good at predicting the future, right? There's 2 circumstances in which we're somewhat adequate. If you are likely to die within 2 weeks, meaning you're gravely ill, right? For my patients, that might be someone who has a cancer that they've been dealing with for years. This is a typical scenario. Let's say they're 70 years old, 75. They've had prostate cancer, breast cancer, colon cancer. They underwent a surgery and some radiation therapy. They underwent some chemotherapy. It got them a reprieve for 2 years or 3 years, but now the cancer has grown, and they're on maybe immunotherapy as a palliative chemo, so no hope of cure, but hopefully gets them a little bit longer. Maybe that gives them another 18 months. But now it's starting to really affect them. They might have rectal bleeding or incontinence and mucus. I'm just thinking through some patients recently. Or I had a gentleman who had lung mets, so metastases to the lung from his, I think it was a colon cancer. And he was a kind of young guy in his 50s, and he would saturate a bath towel each night with the secretions that he would bring up. Bath towel. Not a little one, but the big bath towel. And he wouldn't, from night to night, know if he would make it through that night because he was bringing up so much fluid from the inflammation and stuff. And you get to the point where even the best hospice doctors, will give you medicines to dry up your secretions as best they can. They'll give you pain relief and anti-anxiety medicines and things to help your gut not get obstructed and more pain medicines. But sometimes they can't fix the problem or render you without suffering. And so assisted dying is there for those people who know that they're getting worse. They can see their decline, and the patient has to have intolerable or unbearable suffering. That's not something I decide for them. That's something that they must decide for themselves. When they've got to the point where, I put up a good fight for all these years, but at this point, my dying process is worse than my living process. And I don't want to get worse and see this get worse over the next 2 to 4 weeks or 2 months. And I'd like some help, that in a month when it is worse, I can get you to help me. And so that's what I do. And the vast majority of cases in New Zealand are cancer. In my experience, mostly metastatic cancer, so cancer that's spread and is no longer responsive. We run into a bigger problem with other kinds of non-cancer diseases because they can be harder to prognosticate. So I'll give you an example. If you have motor neuron disease and a few years ago you didn't know why you were losing strength in your legs or your arms, and now it's progressed, and you're having trouble swallowing or trouble coughing up the saliva that your body makes, and you're in bed, you might be paralyzed, and little by little you're losing more and more function. Those patients, it's actually very hard for a doctor to give you a 6-month prognosis because the way that a lot of those patients die is they might have an event where they aspirate some saliva or some gastric secretions or some food or drink, and then get a pneumonia, and then get tremendously ill. They might come to someone like me in an emergency department, get on antibiotics, and often that can be turned around, but it's an unpredictable thing. And sooner or later, one of those events could get you. And for those people, they come to us asking, can you help me? And you have to say, you don't meet the 6-month likely to die criteria. And they say, but I just was in hospital and had an aspiration pneumonia, and I don't want to have more and more of these. And it's very hard to explain to them that the way the law is written, it was written for politicians and by politicians and lawyers to help make things easy for them, but not to make things easiest for the patient. And so as the doctor, you are left telling them you don't qualify, but you can come to me again if you worsen. And so that's the one thing you can tell patients, is that they can reapply. It's not like they're forever cast out. But what the problem is someone who's dealt with many, many patients in that situation, the next time they have something where it's bad enough to become obvious even to their doctors, it might be so bad that I can't help them in a timely fashion. Now, can those patients still get hospice care and all kinds of care and help with their GPs? Absolutely. Assisted dying is not for everyone. Obviously, there are people who will have, let's say, religious beliefs that preclude them from entertaining it. Although it is quite fascinating to see how when patients are put into that situation, you never really know how you will act when you have a cancer eroding through your bowel wall. And for some of these, there have been some really poignant situations where you look at the family dynamic and you might have a family member with very devout beliefs, or even the patient themselves. And it's just interesting to see how that plays out in real life, when really this is all about avoiding suffering, unbelievable suffering. And suffering, again, that you'll often hear from people who are opposed to assisted dying, that you can always have hospice care, and of course you can. But there is quite a bit of suffering that we can't fix with a medicine. We can give you more morphine, but if the cancer has blocked up your intestines and they've stopped, that isn't always something that's easily amenable to treatment. Or when there's so many metastases in your liver that it's twice its size, and that hurts, stretches your liver capsule, or you have bone cancer. There's all of these situations in which the ability to have a peaceful death, to my mind, would be the most humane option if the patient wants that. I'll talk about a case that I think is one of the nicest cases that I've been involved in. It was a nurse that I took care of who, it's often, my stories and my patients are often people who've been nurses or doctors or been around, family members of and watched a spouse or a grandparent die a bad death. That's actually an interesting reminder for me. Can I just see a show of hands? How many of you have experienced in your family and friend circle what you would consider like a death that you wouldn't want, a bad death? How many have seen that sort of thing? Okay, so it's the majority. And what's fascinating is just the propensity for people with direct experience of that situation to then support assisted dying and to want to call in and learn more about it. And the goal in this is just to alleviate suffering. There's a lot of hoops for the patient to jump through that hopefully will improve. There are people and politicians even that are trying to modify the law and improve the law and make it more humane. Like, to my mind, I'll give you like an ideal scenario. I have widely metastatic cancer. I've been fighting it for 5 years. I'm at the end. I don't want to get any further. I'm already bedbound. I already require cares full time. And I would like to be able to call up my GP and just say, Simon, can you help me, please? I've got this problem. And that, in my mind, and imagine that this person who's known me for 20 years, that I've been living here, can then help me through that period. That would be my ideal. That is not at all the way the current process is. The current process is, if you were to phone, you'd dial the 0800 number. First of all, you'd go to a website where you can't even easily find the number. So if you Googled assisted dying right now, and I would encourage any of you who are handy with the Google to do it, you'll get probably the first message would be, don't commit suicide, here's a suicide helpline. And you just think, come on now. And you'd scroll down and you'd eventually find the one from the actual assisted dying service, but it'd be kind of hard because it wouldn't be that high up. And then you'd go through, I forget how many, I don't know if it's a ton of pages. You'd have to scroll down, pages and pages and pages. And then down here, in the middle of the text, you'll find the 0800 number, right? And I've been saying this for years, like, why would you make it that hard? But it is what it is. And then you'd call, and then they would put you through to someone like me. So if there was one in your area. And one of the problems is there's not a lot of doctors that are doing assisted dying. And it's counterintuitive. It's not for the reason you might think. You might think they don't want to. They don't want to have anything to do with causing someone's death. But in reality, plenty of them are interested in doing it, especially GPs. But the GPs tell us that for the small amount of reimbursement that assisted dying doctors get, the cost of closing down their clinic for an entire morning, right? They still have outgoings, right? They have nurses to pay and receptionists and things of that nature. They say we can't not see the patients. Like we just simply, it's financially uneconomic. And you just think like there's got to be some better way of doing it. So I can do it because I do it on my days off, purely because I believe in it, and I would want a doctor to come help me if I was in that situation. And so I can't be a hypocrite. If I would want a doctor to help me, then I have to be willing to help others. And so, you're driving out to the Hokianga, you're driving, like covering a huge amount of territory on your days off, trying to do this work. And some things have to change to make it more easy. Like, I think we all deserve that if our GP wants to provide the service, they can. Like, that only makes sense. But right now, most of them just say, it's just not possible. And I already work so hard, I'm not going to do this on Saturdays and Sundays. But that's the sort of state of play of it. I'm conscious that I've talked a lot, but we'll get to some questions, and then I can talk a bit more about things that are of interest to you. Does that give you an idea of how the process works?
Yeah, that's the good story about the nurse.
What?
You were going to tell us the story about the nurse, the good story about the nurse.
Oh, yeah. So it was an example of maybe how you could have, I don't know, the best way to go that I can think of, or at least a really beautiful way. This person had obvious, health and medical experience, nursing experience, and had a bad cancer, as many of the patients who qualify for assisted dying have, and had been dealing with it for a long time, but got to the end of that path, and she knew she was getting worse, and she got assisted dying involved, and we did the interviews, and then the second doctor has to come along, independent of me. I don't get to know who they are, and they have to assess the person and make sure their assessment has to marry up with mine. And if they do, then the person can get approved. If their conclusion is quite different, that the prognosis wasn't met and there's coercion and whatever, then it won't go ahead. That's a stop on the process. So I think that's a very nice fail-safe, personally.
Does it happen very often?
That it doesn't go ahead due to coercion?
I know, just due to the two doctors.
No, it's rather uncommon, because I think most of us are pretty conservative, and frankly, the patients, by the time you can get a doctor to, in a formal way, agree that you have less than 6 months, very often you have 2 or 3. So it's just the nature of medicine. We're conservative creatures, right? We don't like to go out on a limb and say, it's fine, or everything's great, or it's super bad, and you're going to die. That's just not how we operate in our day-to-day life. And it's the most unnatural thing to go to these doctors and say, what's your thought on prognosis? Oh, so many variables. Yeah, okay, but let's talk honestly. And what does the data show? There are prognostic calculators. There's cancer registry data that helps us a lot. And we use those, but it's kind of an uphill battle. And yeah, I can tell you that so I think the number is something like 50% of people who seek assisted dying actually get assisted dying. That could be for multiple reasons. One, they changed their mind, or they didn't qualify. But a fair chunk of those, in my anecdotal experience, are simply because Goldilocks. They were too sick and didn't qualify, not in time, or they were too well. And we said, no, sorry, it's not for you. And a fair bit of those will then recontact in less than 6 months and say, now I'm in hospital, I've had a horrendous bowel obstruction, they had to do another surgery, or what have you. I had sepsis, bloodborne infection, and I'm back home now and I want to proceed with it. So there's a fair bit of people that are told that they don't meet the 6 months who end up meeting the 6 months or needing it and not getting it. So it's a mixed bag. Where we're accurate is in telling patients that their prognosis is less than 2 weeks. Like in the literature, this is from the medical literature. So we're good when it's kind of obvious to everyone, right? You've been admitted and you are in rough shape. That's kind of obvious. You can believe the doctor 70, 75% of the time. If we tell you that you're likely to live longer than a year, we also have decent, reasonable percentages of being accurate with that, right? But in between, we're not. And so the 6 month was chosen off of nothing. It's arbitrary. It's not like anything happened special at 6 months. And that's the irony of it, right? A lawyer and politician drafted these numbers, and they looked at other countries and they came up with their best guesstimates of things. But what is the difference between someone who's going to live 5.5 months and someone who's going to live 7 or 8, who is suffering intolerably from a terminal illness that's likely to cause their death? So the way the law was originally written, it would be a grievous and irremediable condition. That's vastly more reasonable because it allows you and your doctors to have a conversation about how grievous and how irremediable and make some plans. But that got struck out and changed purely so they could pass the law. They had to make all of the hoops and hurdles that I talked about. Those were put in there to satisfy a minority of the voting public, right? 66 or something, 63% of people said they want this law, but you still had to get buy-in from the most loud and vocal people saying, you're going to kill everybody. So at the time they said, there's some horrible things. Like they said, you're going to prey upon the disabled and kill them off, and you are going to prey upon Maori and Pacifica and disproportionately kill them unnecessarily, right, inappropriately. And what's been fascinating for me to actually see in practice is how damn hard it is to actually qualify. That if you don't have a supportive whānau, if you don't have some means and some ability to make the video calls, or to someone to set up your appointments, or someone to negotiate with the hospice because they won't allow assisted dying on their premises. So imagine that. Imagine you're in your final day, and you have to get carted off in an ambulance somewhere else. And that means that you and your friends or family and the staff had to arrange for you to go somewhere else. So I've literally had the conversation of like, where am I going to go? I don't want to go to my daughter's house. She's got young kids. That's not quite appropriate. And like, this is while you're bedbound and you've got a cancer, in this case, eroding from your joint and muscle out of your skin. You're in your final phases and you're having to worry about where. I mean, think about that now. If you had to arrange ambulance transport for next Friday, Like, that's a lot to put on people.
Does it have to be within a building? Could you not just go off to a nice quiet?
It can be done wherever you and the doctor agree. So there have been stories of people doing it, having it done, sitting next to their partner in the back seat of their Mustang, old-fashioned, historic car that they love, because that was a happy memory, right? There have been people having it done in gardens and places, but I guess that's not the problem. I'd be happy to do it anywhere. I don't think you should burden a person who already has enough stuff going on in their life with having to work out one more thing when they've got a room at hospice they might have been in for weeks. It's their home. Some of them, these folks, if a rest home doesn't allow it, for example, they have to arrange an alternative. But many people in rest homes would have given up their unit, given up their little home or their assisted living facility or whatever. They've been in this new place for months. It's their new home. So it's their last home. And then if the place doesn't want it to happen. So I have very strong feelings about this. I don't think any of these entities I've talked about should accept or be given a penny of public taxpayer money, if they're not going to help, or not even help. I don't want their help. I just want their allowance to do what the patient wants. And I don't need staff's help for this. I mean, if I did this with any of you, on the final day, after going through all these, jumping all the hoops and hurdles, on the final day, I come in, put an IV in your arm, and give you 3 medicines that are the same medicines I would give you. It's ironic, as an emergency doctor, if I was intubating you after a car wreck, because you need to be on a ventilator in an ICU or you need to go to theater, or if you were having a theater case, same medicines that would be given in that scenario are given, but just in much higher doses. So instead of a little tiny touch of this and this and this, we give you a massive amount of this and this and this. And how it actually plays out is you've got the IV and you've given your final consent, and you have to be able to give informed consent on that last day. You're given the first of these 3 medicines. And in my experience, the way I deliver the meds, the person typically falls asleep in 10 to 20 seconds, and then takes their last few breaths. Sometimes those are a bit noisy because they are final breaths, and then becomes completely unresponsive and deceased. I then leave the room, leave it with the family, and come back 10 minutes later to formally pronounce them dead, right? No respiration, no pulse, the whole bit. And then I leave the house. And that's how assisted dying actually goes. So getting back to a long time ago, that nurse, she was getting increasingly weak and tired, and she saved up her energy so you have to pick the date yourself. No one assigns it to you. Choose when you think it'll be right. And it is kind of hard because you don't want to choose too late and then miss your window and not be able to qualify. For example, imagine if you have brain metastases or a bloodborne infection or a bowel obstruction and you're septic, or you have so much pain that the medicines you're on render you a bit confused. If you have those things happening, you may not be able to give informed consent, in which case it won't apply to you. Like the process stops. Essentially, there's many ways of you coming off the path if you don't qualify. And so this what?
So you nominate tomorrow on the next day.
Well, some patients say to me, "Can you just make it for the first available and realistic date?" And fine, I can do that, but it's still a little ways away. There's a 1-week delay built in to get the paperwork done, sort of at the end of the process, to get the meds couriered to me. Now, mind you, the medicines are available in every emergency department in the country. So at work, I'm 2 meters away from them, right, in resus. But there's only one pharmacy in the North Island and one in the South that will provide the medicines and package them up for you and courier them to you, and you've got to be home to receive them. And it's quite this process, so it can't happen easily. So this person was sick and tired and fatigued. But what this patient did was set aside a week of recovery where they just focused on eating and drinking as best they could, get their energy up, so that they could have a living wake during the next week. And they invited family from all over to come in a scheduled way so they didn't get too tired, right? On Monday, Tuesday, you see the grandkids, see this person, see that person, record some videos for the family so that the kids as they grow up will have a message from Nan, for example. Have a casket that in this case was cardboard. It was one of those natural burial things. And I think it was with, what's the name of the Graceful Undertaking, right? Is that the one? That do like natural burials and whatnot. And so this thing could sit in the kitchen or living room, and the little grandkids would put paintings on it and put mosaics and put little jewels on it and they would write messages and do it as a family. And it was really nice. Some patients will ask if this costs any money, and it's free for patients. It's a service from public health care. Well, we still have public health care in this country. And it is no cost to the patient. And my time is paid for by the Ministry of Health or to Health New Zealand or whatever. So, yeah. If I say good or bad things about any of these things, it's not because I have a financial interest. So that patient I referred to earlier had a really nice last week and then was able to just say goodbye in such a beautiful way. And yeah, there was elements of Maori stuff in there as well. It was just a beautiful, beautiful way of going. And the alternative, which I've seen in the ED so many times, is very, very different. It looks nothing like that. Yeah. Any questions from anyone? When I'm doing these assessments, I need to talk to their family doctor, their specialist, and their family members. So like I need to, if I'm going to be figuring out if you're being pressured, I'd like to see you alone. I'd like to see you with them. I'd like to see the family alone for a minute to have a conversation and reach a conclusion. So that bit, at some point, I do need to talk to some family or friends of the patient to get a richer picture. On the day of assisted dying, it's their choice. So if you were to say, I want everyone to be there that wants to be there in my family, 30 people, huge, huge cultural thing, fine. If you say, I would like my family around, but at the final minute, I just want my husband there, that's absolutely fine. Many people will choose something like that. A few, very rarely, will say, I actually don't want anyone to have to see me in at that point, and so we'll just ask them to leave the room. That's fine too. It's up to the patient. No, it's up to the patient. What's fascinating that prompts a story. I was in a rest home that did allow assisted dying, and I would say check with your families, your loved ones' rest homes, and ask them about this. Put pressure on institutions to ensure that they provide this legal healthcare option to their patients without putting up extra roadblocks, because it won't change until you change it. Until you call your mother's rest home and say, why won't you? Will you provide assisted dying? No. Why the heck not? And then if 40 people go out and have those phone calls, and then 400 people go out and have those phone calls, we might see an improvement. I think we will. What was interesting was I did an assisted dying early on when the law was still pretty recent, pretty fresh, where I always ask the staff, do they have any questions? Is there anything they were wondering about? And the question from like a healthcare assistant was, like, did she suffer at the end or like resist? And it flabbergasted me, but it shouldn't have. I should have understood that people don't know what this process is or how it works. And we're prohibited from talking about it with a patient unless the patient brings it up with us. I'm just going to go to an aside now because this is the most insane bit. If you had a cancer and you went to your cancer specialist, imagine the scenario. They tell you, oh, you've got a bad one. We can do chemo or surgery on it. And that's it. And those are your options. And then you asked, what about radiation therapy? And then the oncologist told you, I couldn't talk about radiation therapy until you asked first. But now that you've asked me, it is a good option. It's available to you. It would have this success rate and this failure rate, and it's an option. And then you'd say, like, it's ridiculous. Why didn't you tell me? That's the scenario that assisted dying is in. Unlike any other law, we have restricted it so badly, taken away so much agency from the patient that that's all they're left with. If this person doesn't bring it up because they didn't know it's legal, they haven't been following the news for the past few years, they have not a ton of education and the ability to seek out this information and use the internet. If you didn't know about it, that's it for you. It's not an option because you won't bring it up with the doctor who's treating you. The doctors are actually, it's a gag law. The doctors are prohibited from mentioning it as an option, even if it would be an option for you, until you ask me. Then I can say, well, as a matter of fact, there's all this information. I'll give you the number and you call them and this is how it works. Can't say a word about it till then. So it's interesting. They didn't want it to be a coercive process. So they've made it an incredibly unfair, it's almost like reverse coercion. We're going to make it so hard for you to access. And of course, that impacts dozens, if not hundreds of people across the country on a very real basis. So we're harming little by little bits individual patients all the time in an effort to not harm someone from a theoretical risk, which is kind of like a backwards thing. Also, from patient autonomy point of view, we've been telling people and med students, teaching them for decades to respect a patient's right to choose and to decide what things they value in their life and what they think a good death would look like and how they want to enact their end-of-life choice. And then in this case, we take all that away and say, yeah, but in this one case, no. So it's fascinating. What was the point I was trying to make before I went off of a tangent of a tangent? Can anyone remind me? I'm not...
You were talking about someone early on when it was all quite fresh.
The question was...
Oh, yeah. So the healthcare assistant was like, did they struggle much? And I was like, oh my God, are you kidding? Like, I don't hold them down. I don't use a pillow. You have to be positively saying you want it and be of sound mind at every point of the process. Another person was very tearful, elderly lady whose husband was in a bad state. And I tried to figure out what was troubling her so much about it. Do you want to talk about it? Do you want to ask questions? And I realized that she thought she would have to administer the medicines because hospice had given her medicines to administer to her husband when he's in pain, right? Morphine or what have you, this pump, this, concoction. And she was under the assumption that she'd have to do it. And she said, I can't do that. And I said, you don't have to. And so with that healthcare assistant, it was a good chance to gather them all in a room. So bring all your staff, all the nurses at this place, ask any question you want of me, and I'll answer it, honestly. And I did, and I feel like at least there was however many, that was 10 people that day who went out with some fears dispelled. And the amazing thing is every family that you do it with, I feel like you're creating maybe 2 to 30 more people who understand the process. And a very common reaction from families would be, that was so much nicer than what happened to my great uncle Bill. He had a horrendous death. And or I didn't know it was that simple and painless. Like that was it. They just essentially fell asleep in 10 to 20 seconds. Yeah, it's like anesthesia. You know how the anesthetist says, can you count to 10 or whatever, and by like 3 or 4 you're asleep? It's like that. And and so I should say, I don't think it'll be a lot of patients that ever need assisted dying. It will be a small percentage. Many people die quickly, die painlessly, die comfortably or suddenly. But there is some percentage of people who die bad deaths. As the hands went up earlier, like it's obvious that some of you know people in that scenario. And if they want it, it's really nice that they have an option that can turn like an inexorably bad death full of suffering into something that can potentially be quite gentle. It's making the best of a bad situation, in my view. And so sometimes people will ask, like, how does it affect you? And doesn't it like sort of, isn't it very troubling to do this to someone? But again, it's counterintuitive. This is one of the nicest things you can do to someone who is suffering tremendously, who other forms of painkillers and medicine and hospice care and oncology care can't help anymore. You can at least do this one thing that helps reduce their suffering in the world. And for me, that's not a bad thing, that's a good thing. So I do not have qualms or problems with this. Yeah, so it's worth talking about. So medical doctors or nurse practitioners are allowed to do assisted dying. They have to essentially put their name on a independent list. It all has to be done essentially at arm's length from the hospital you work for or anything else. It's a separate thing. It's its own thing. So it's got its own training program, and you do that online. And then you may or may not get approved, and then you're on a list, and then they will go down that list to choose people depending on the area you live in and your availability, to see if you're willing to do it, if you can do it. There are little, what's the word for them? Like little doctors groups where we meet, peer review, I guess you'd call it, where we talk about cases that are troubling or hard, or we just vent, or we just unburden ourselves with colleagues and talk about cases. And that's quite regular. And I think that's a pretty important part of it. And yeah, there are things of that nature. And then sort of lectures, is that the right word? Teaching sessions, where they will have a psychiatrist come and talk about issues of consent, issues of, dementia, issues of families that are violently opposed to things, and how you deal with the delicate situation. So yeah, it's like an ongoing process, and I think it would be good, and I think there are modifications to this, where it's going to be a doctor who's been out in the world for a few years doing this. I think that helps. Once you've seen enough people die in front of you, I think it helps you understand what it's like, rather than someone maybe straight out of like specialty training, like a year one doctor. But so that's the scenario. And I think all of us are doing this on the side of a GP practice, an anesthetics practice, in my case, emergency medicine, which is ironic because in my day job, I will do anything I can to keep you alive. I mean, if it's an appropriate scenario, if it's, with the patient's wishes, all of that stuff. But it's all about recognize disease before it kills the person, catch it, and try to reverse it, right? It's completely diametrically opposed, right? There, it's all about like seeing patients fast, and we're sometimes overwhelmed by numbers. Assisted dying has been a nice counterpoint. I wouldn't have wanted to do it when I was young. I was interested in being on the rescue helicopter and doing hyperbaric dive chamber stuff and being in a trauma center and all of those things. But as I got older, I realized I find it quite valuable. Like when I get your information, when you contact assisted dying, I will visit you at home, which is quite a special thing, right? Doctors really don't do house calls that often anymore. And so for me to get to go into a home and see the circumstances that person's living in, it might be someone with vast wealth. with a waterfront home, and you'd be surprised, and this is I think interesting, you'd be surprised at the number of very wealthy people that will seek assisted dying because they are used to having agency in their lives. They have founded a business. They have always kind of created the world the way they wanted and expected certain things. And quite often, like, it seems like a disproportionate number will then say, this suffering is not how I had intended my life to have played out. Whereas I think the process is skewed a little bit against a person who lives very rurally, who is in a house that's almost a shack. It's falling down. They're living in poverty, and it's a very different scenario. It's harder for them to access things. It's harder for them to make an appointment with you, and just all of those things get harder. So it's interesting how many counterintuitive things. You know, you might have thought, oh, it's going to be those people that will turn to assisted dying. It's actually so hard for them to access that it's quite challenging. But as a doctor, it's amazing that I can get out of the emergency department and go to their home and pat their little dog and talk with their family and talk to them for like hours sometimes, which I can't ever do in the ED with you, right? Like, I need to move on and get to the 30 people in the waiting room or the whatever. So it's been a really cool thing for me to be able to help patients with. 3 medicines. It's 1 IV and you get 3 medicines. Same as you would in an anesthesia case. If you're having a surgery next month, they'd give you these medicines to knock you out. Yeah, so like often I'm still giving it and they've become unresponsive. They get the second medicine, which is a huge quantity, huge. And then they get the third medicine in a huge quantity to ensure that they are insensate. They feel nothing, hear nothing, see nothing. They are completely sedated and anesthetized. And then the third medicine is given, and the combination of all of those renders a person dead.
So that's within a few minutes.
But to be fair with you, they have likely died in the middle of again, at the 20th second, right? That medicine's going in, it's going in such a big level that when you get sedation at that level, you can't resist falling asleep. It's about 10 to 30 seconds. That's it. The rest of the medicines are there to, essentially, they're redundant. They're going in, but you have, for all intents and purposes, died. I will come back in 10 minutes later after your family has had a chance to handhold and talk and whatnot, and officially declare you dead for the purposes of a death certificate, but that's well after the fact. Despite dementia being the most common thing patients will ask me about, or community groups that I talk to, that bridge is probably a long way away, even though it's the number one concern of every group I talk to. They understand, like, they don't want to be, dementia is a fascinating process because it doesn't just, you don't just stop being able to think things. It, in its last stages, affects your ability to swallow and breathe and do fundamental core things. And so patients obviously want to avoid that path, but there needs to be a greater knowledge in the community and more of an appetite to push for change before that happens. So that's going to be up to you. It depends. Like, do you want to forward this video to 50 of your friends to achieve a society where those laws happen? That's on you. But yeah, that's on all of you, all of us. So does that answer your, and then in terms of the other changes, there's about 15 of them that can make the process more humane. There's a group called End of Life Choice, EOLCNZ, and I'm part of that group and have been from before I started doing this. They support assisted dying laws. They help the act get passed. They have incredible folks that are trying to put out good information and trying to they're like an intermediary between patients and all the rest of the politicians and lawyers and whatnot. So if you're, again, I will put this out there just as a neutral endorsement. I think they're a good group and they're trying to do the right things and their hearts are good. And so help them because they need help. They're running. You have to realize that the people who would change the law, and I do want you to understand, you only have this law for as long as you are willing to fight for it. And the minute you are not, the law will be crushed. And that's the nature of rights and liberties and laws fundamentally. There are loud, vocal, and well financially resourced groups, often funded, let's say, by religious organizations and the like, that can put out, at the drop of a hat, unbelievably distorted radio. And I don't know if you remember when the law was, we were trying to pass the law, the things, there was a thing, this is the thing that galls me. It's been years, but I haven't let go of it. These groups paid for a radio spot that played a lot around the time of the law being looked at. And this was how the radio spot went. I wish I could get the recording if any of you have access to it. Oh, please send it to me. This is the recording. This is what you hear on the radio. There's a ringing phone and then a lady picks up and it's like the University of Auckland or some university. Mrs. Smith, you can come pick up your son Tommy's things. And she's like, well, what do you mean? They're ready. Like we're trying to clear the dorm room out. You can get them now. And she's like, what are you talking about? Oh, well, he had assisted dying last Sunday. What are you talking about? What the heck are you talking about? Oh, he was diagnosed with a terminal illness last week. And 3 days later, he had his assisted dying. And he's gone now. I assumed you knew this. Sorry. Can you pick up his things? And then that's the end of the radio spot. Like, don't vote for assisted dying. It'll kill everybody. And this was professionally put together. So the people fighting for assisted dying, like end of life choice and others, are largely older folks, maybe pensioners, who've had some experience with it. And not saying anything about this group in particular. I say that with gray hair myself. And they don't typically have a ton of power and tons of money behind them. Like when we led a march to Shane Retty's office, he's the MP at the time, and still is, right? It was a ragtag group of folks whose median age was probably, 70. Did any of you go along? Thank you. And so when we had that walk, it was a bunch of people, like normal good people, trying to do their best.
Died since. We're getting older.
Right. And, we said, can you please support it? And of course, for, I think, religious reasons in his case of being, I think, Mormon, he's not willing to go for it. And he, I think, helped perpetuate some of the feelings against it and say, it'll get out of control and I don't want any part of this. And he was saying things like, the oncologists are against it and the hospice doctors are against it, et cetera, et cetera. And chose to not support it. Fair enough. Each to their own. But my point going back was the people who would go against it, incredibly well-resourced. If you just look at the quality of the pamphlet they'll hand out, right? The end-of-life folks are printing this out on someone's printer at home, right? And it's ragtag and it's the best they can do. Please donate your $20 to end-of-life choice or whatever. And the ones against it have television and radio spots that are professionally produced and shiny and amazing. And it's just the nature of the world we now live in. There was a review. It came out with some potential improvements, like, 15 or 20 of them. And again, go to End of Life Choice website because they can actually talk to you about list all of them for you and you learn about them all. But yeah, there was a bunch of recommendations and now an MP has supported the majority, maybe not all, but lots of those recommendations. And I think if they can get I don't want to make up a number, like, I don't know, 60 MPs to somewhat support it, it can then go to the bigger group. Otherwise, it may not. And so it's up to you to write to your MP and say, get off your chair and support this thing. I don't care so much about your personal beliefs about it. I want you to respond to what the community wants. And if all of you did that and all of your friends joined in, that has meaning, you know? So yeah, be active, get involved, do that sort of stuff. And maybe that bill will get picked and maybe it will get voted for and supported. And that would be good for patients. You can bring it up with your doctor, let's say your GP. They can't bring it up with you. So that was that scenario I was telling you about of imagine another condition where A and B are told to you, but not option C, unless you ask me about C. Then I can talk to you about C. It goes against everything we have said about patient autonomy and the patient deciding what course they want their life to take. It goes against all of that. This is the only condition where you have to go home completely unaware of the options available to you. And that's happening right now. So again, we like to perseverate and keep railing about, not we, they, like to perseverate about the risks. Well, these are not risks, these are actual harms going on right now, but no one's chronicling them or talking about them or trying to change. Very few are trying to change them. But the harm is, yeah, absolutely, patients are going home having no idea. And maybe some of them would have wanted to know. Maybe some of them would have opted for it, or at least like the option of having the thing mentioned to them so they can ask questions and say, how does it work? Could I qualify? Maybe the answer is no, but people deserve the right to know what their options are, I think. Oh, that's a superb question. Oh, I could talk about that one for a while. There are some specialists who have said to me, I will not talk about that at all. And I'm like, I'm asking you about your patient that you've done chemo for. I need to know some medical stuff. I'm not going to talk about that at all. Yeah, but you have to at least tell me something about the patient's care because you were their carer. Or I'm not going to talk about that at all. And I was just flabbergasted. And I said, it's your right to not support assisted dying if you don't want to, the way the law is currently written. But you can't abandon your patient and leave them high and dry. You have to put me through to someone who will tell me about their oncologic history and what they've had and what their prognosis is. So he put me through to one of his nurses or something. I had to do a workaround and talk to others because he didn't want to engage. And locally, there's also issues with providers who, for ideological reasons, will not countenance it. So they don't provide it, they don't want to deal with it. And again, to my mind, I have a very simple solution. I like things to be clean and above board. Don't take public money for healthcare if you're not going to help the patient. In the ED, could you imagine if I said, I don't believe in this and I'm not going to treat you? That would be disgusting. I will treat you even if you spit on me, even if you call me names, even if you hit me, I will try to do my best to take care of you. And the thought that you can't get a legal public healthcare treatment because of what that practitioner believes it's insane. It's insane to me. But I was raised with different values than that. And I think with a much more European mindset of, like, you go to the Netherlands and there's talk around the dinner table about, let's talk through what's my death going to look like. These are like 20-year-olds talking about this stuff. And some of their biggest organizations, like the End of Life Choice thing, their equivalent is like millions strong and really, just really a part of the fabric of society. And that needs to be the case here as well. It will come, but it's going to come in potentially generations if it doesn't even get reversed before then. And so the real danger, in my mind, is that you will get people who reverse it. I think the American experience shows you how tenuous your public services are, and the current political situation also shows you how tenuous your public services are. Like they are sort of like almost treated as privileges, and they can disappear if you don't support them. So support them. It's assisted dying. It already pops up on the computerized death documents as assisted dying, and then it filters through. And there was always a concern that like maybe, I don't know, life insurance or health insurance, I don't know, something like that, something financial wouldn't pay out if you died that way. But I think those things have been thought through by the lawyers, so that's probably a good thing that they did. And it's assisted dying, and it's not suicide. You were dying already of your metastatic cancer, and this was just helping you not suffer excessively and unnecessarily during the last 2 weeks or 2 months or whatever of the process. Yeah, there's a handful of us. It's obviously not just me. I'm vocal, I think, because it's my personality. It's how I've always been, and I have. If I end up losing things because of this, then so be it. Then it's meant to be. But I need to say what I need to say and do what I do. So I'm happy to. It comes at a price, but so be it.
I hope that your outspokenness does not affect your ability to do what you do.
It does. It does. Let me tell you, it does. But so what? We can't live our lives in fear and do the wrong thing. Like, that's no way to live. They get turned down. It's no. Anyone can reapply as many times as they want, subject to the vagaries of their disease. If they worsen precipitously, then sorry, they're out of luck. But they can reapply. But it's very, very simple. All of these are like binary yes, no. You don't meet that. You can't imagine you're this is you. You are an immigrant from Wales. You are 80, and 40 years ago, 50 years ago, you came here, you've got a pension, all of this stuff, but you're on death's doorstep. And someone like me says, I have to follow the rules. I've got it in my bag. I've got to follow all the rules, right? 21 pages of paperwork. We've got to go through it. I've got to go through it. And I tell you, I ask you, are you a citizen or a permanent resident? And you've got to be in order to qualify. And they're like, yeah, I am. I have a pension, blah, blah, blah. So I need to see that. I have a photocopy somewhere, I think. No. The lawyers made the law so that it says I have to see the original. And it's a birth certificate for New Zealand or a passport. It can be an expired one. Or that sort of really like strong evidence, right? That you're a citizen. And this person ultimately said, I'm not going to send my 80-year-old wife up the pull-down stairs to our attic to go rifling through boxes on the last weeks that I'm on this earth. He basically said, go to hell. I'm not going to do that. See you. And I 100% agree with him. But it's kind of unfortunate. Now, there are people that can help with that a little bit. There's now folks that from the service that can look up your information and talk to the Department of Immigration, DIA, all of that citizenship stuff, and can find your naturalization papers or whatever. But it takes a while, and again, it's not easy. I mean, if I had to do that right now, it's going to take hours, and I'm going to be on the phone on hold, and it's going to be a challenge, and it's not a great, nice, pleasant situation. I don't know. I'm not going to even go there. I'm not going to violate the law, period. Like, full stop. It is what it is. The second doctors start violating the law or the rules or the procedure, you've lost your trust in the whole thing. So, no, like I've had people ask me stuff, and the answer is of course not. Of course not. It is what it is, and it's written that way. And if you want to change the law, the onus is on you, not on me, to do an illegal act. And I mean, forgetting about any risk of going to jail or whatever, it's not right. It's not the way the thing is. So,
Well, it would also just feed the prejudice against.
right, sure. Like, yeah, once you start doing illegal things, that like, what do you have left? No. So no, no. So it ends up being, the alternative might be that the patient is super sad, or might get angry, or might get depressed, or what have you, and you have to talk to them through that. Can't you do this? Can't you just do this? And like, you can't. It's just, no. Really difficult for them to meet the criteria of that 6 month, because often they will decline and die with a pneumonia, which is unpredictable. And so they're too healthy to foresee their death and make a prognosis of less than 6 months, likely to cause their death in less than 6 months. And then when they do get sick, it's often overwhelming and precipitous, and they may not qualify. So it's super challenging for patients with congestive heart failure, neurodegenerative conditions, like some of the ones we talked about, COPD, and a host of other chronic illnesses. It's challenging. I'm not saying it's impossible. There are going to be some that get through and get approved and go through it, but the law is not set up to help make it easy for those patients, which is unfortunate. Getting rid of the 6 month rule. It's arbitrary and unfair, and in some cases inhumane, because a person has to plan out their death to meet a date and to qualify while they still can make it through these hoops, or they don't meet it for the Goldilocks reason, too sick, not sick enough. And if you eliminated that arbitrary and absurd 6 month rule, and you let it be a grievous and irremediable condition that you and your doctor talk about, that's reasonable in my mind.
It's 12 months or 18 months. You don't have a time.
I think at a minimum, it needs to be 12 months. Like, that's just blatantly clear to me. Again, because we can be more accurate about our prognosticating beyond that 12 month mark. But yeah, I think the number, this should be about you and your doctor having a meaningful interaction and talking about the specific aspects of your disease, your wishes, your vision of how your end of life will go. You know, your goals of care. We talk about that for almost everything else, but in this case, no. So yeah, I guess the 6 month thing is random and arbitrary and unfair to patients. We'll talk about that separately. Yeah. I'm happy to chat about it. Anyone who wants to chat afterwards, I'd be more than happy to talk about it. No, I'll be in back. I'll take questions for as long as I can. I've got a thing to do, but you're welcome. Thanks for coming. And yeah, good luck out there.